Hi, everyone. I feel like I'm at the Oscars. I almost fell down the stairs just for effect. Let me get my presentation up. No, seriously, though, if somebody would have told me that I would someday be presenting with Andrew Tatarsky and Carrie Wilkins, I would have peed myself. Oh, can you not hear me? You didn't hear my pee myself joke? Is it? Okay. Sorry, that's welcome to the IMAX. I'm really sorry, this is so bright. My name is Adelya Urmanche. I'm a postdoc research fellow at Mount Sinai Beth Israel, and I'm a proud member of the executive committee of the Addictions Division. Thank you actually for both those talks because they kind of set me up for my talk today as well. As Andrew said, sometimes we can do everything right and know all the things, and yet we know the reality. Sometimes people still die. And that's what I wanted to talk about today, and I'm sorry, this is right before lunch. But what is really striking to me, and has been since I was a trainee, not too long ago, obviously, is walking into these spaces where there are people who use drugs, where there are harm reductionists, where there are clinicians, peer workers, and feeling there's no oxygen because it's all just grief. And it's so palpable whenever I enter some spaces, and I just feel it. And I felt it when I was doing groups, again, in the midst of, the overdose epidemic. And so if you get anything out of this presentation today, and I'll talk about, obviously, loss and wellness, but if you get anything out, it's just that we need to name that, because that exists, and that's very real for probably many of us in this room. I have no financial disclosures. If you want to pay me, please feel free to talk to me, and then I'll get some financial disclosures up there. Yes, please. Later, after lunch. Just a disclosure that this presentation started out as a paper that I wrote in 2020 with the unfortunate title, Bearing Witness to the Epidemic. I wrote it in 2019, and then the pandemic hit, and I was like, great title, Adelya, nice. And then recently, I presented this with some harm reduction colleagues at the Puerto Rico Harm Reduction Coalition Conference. So it was a variation because we were talking about harm reduction workers specifically. And right now, I'm preparing a chapter for the Routledge International Handbook of Drug-Related Death Bereavement, which is, on the one hand, really cool. On the other hand, kind of wild that we need to have a handbook for this particular thing. So the handbook is going to be out probably, hopefully, next year, 2024. But what I talk about in the chapter is sort of the sampling that you're getting today. So we already said the context, right? Roughly 2,700 probably overdose deaths in New York City, closer to about 5,800, I think, in New York State. And we talked about the 108,000 across the nation. I will note that approximately 10%, according to the CDC, approximately 10% have been recently released from an institution, such as an inpatient rehab or psychiatric hospital, and approximately 20% have previously been treated for SUD. And I say this why? Because we don't actually know the prevalence of how many clinicians, how many providers have lost somebody to an overdose death. We can only estimate because of things like HIPAA and 42 CFR and just poor record keeping, honestly. We don't have a sense of how prevalent this is, but I know people. Some of you might know people. Some of your colleagues might know people. So we know that this is happening. So I just wanted to point that out. And what do we know about drug-related death bereavement among clinicians? Well, to be honest, not much. So we do know there's some research, very recent, and as you'll see by the dates, that different providers are impacted, not just clinicians, not just psychologists, but also psychiatric providers and residents, harm reduction and peer workers as well. There is a range of grief-related reactions that have been documented already. And this is also relating it to the suicidology literature. So clinicians, providers who have lost clients to suicide have experienced similar grief-related reactions. But this is what we know so far. That providers often experience sadness, guilt, anger, helplessness, nightmares, flashbacks, self-questioning and self-doubt, anxiety and frustration, feeling devastated, exhausted, and demoralized. So this is what we know already, just in the last, and you see those dates, 2022, 2021, right? So this is just beginning to be actually researched. And lastly, I wanted to point out there's even a word for this now, overdose-related compassion fatigue, right? So we know compassion fatigue. We've heard about vicarious trauma, but now it's in the context of, again, all this death around us. We can have a genuine reduction in empathy, both for our colleagues, for our clients, as we talked about. And what are the barriers to bereavement among providers? So the way that I like to look at it and the way I like to set the context is there's sort of two things, two barriers that intersect. So one is the nature of the overdose death, which I'll talk about, and the other is the nature of our jobs, which I think, hopefully I can convince you, that is also a barrier to bereavement among us, among providers. So first, the nature of the death. So we know that overdose deaths are actually qualitatively different from other deaths, and I'll talk about how. There's a perception that death is self-inflicted and avoidable. There's also a perception of ambiguous intentionality. So folks are not always sure, oh, did that person overdose because they wanted to overdose? Is this a suicide attempt? Some of you might have heard these types of things. This stigmatized prerequisite, right? We've talked about stigma, so thank you again for bringing that. Drug use in and of itself is stigmatized, right? So, of course, dying related to drug use is also stigmatized. And this really, again, I highlight what my colleagues have already said about stigma, because I think this shows that stigma is, transcends life, transcends death. Which is why overdose death is often called a marginalized death. It is not considered a noble death, such as, fighting with a chronic illness for a long time, or a tragic accident that just happens and nobody knows why, right? This death is not considered noble. This death is considered, I don't know, some of you might have heard some of these things, like, oh, they had it coming, it was bound to happen, what else did you expect, right? So again, similar stigma that exists when the person is alive still persists even after their death. And how does that impact grief? Well, actually, a lot of this literature we know from family members, because they were the ones that were very loud about, this is hurting us, this is painful for us. So again, while we might not know so much right now about clinician and provider experiences of overdose bereavement, we can look to the family members. And it's the same. Guilt, relief, interestingly, shame and stigma, unworthiness to grieve. In fact, some research studies have showed that a lot of family members are not honest about how their loved ones died. They say it was an accident. They're either very vague or abstract about it, or they simply say, it was another reason. And what does that do, right? That creates a lot of judgment towards the bereaved, right? And a lot of pity. And it also deprives people of social support and meaning making, right? Those of you who are more familiar with healthy grieving, for example, know that meaning making is such an important part of grief. And when you don't have that support, when your grief is not acknowledged, you can't have that, and you can't grieve in a healthy way. And so that's why this grief is often called a disenfranchised grief. Now, the nature of the job. So, we know, among providers, there's a general human heightened aversion to acknowledging our own and others' finiteness. Brian, you didn't mention my talk this morning, and I'm wondering if that was some sort of subconscious aversion, maybe, to talking about loss. I won't analyze it, but we'll talk later. So obviously, I want to also point out that this is sort of more obvious in Western cultures. So in Eastern cultures, people tend to look at death a little differently, but in Western cultures, certainly we want to We don't want to talk about death. We don't want to talk about loss. We don't want to talk about our death. There's a concept of death anxiety that might be familiar to some of you. So that's definitely at play. There's a lack of training on death, dying, and grief. How many of you had any kind of formal training on death, dying, and grief as part of your higher education? Raise your hands. Oh, yeah, it's like 4 or 5 people. Yeah, that's weird. Like, that's really weird. Not only just because of overdose deaths, right? I mean, I'm talking about this in the context of overdose deaths, but people die. Sorry. But it's a natural process, right? And we need to know how to deal with it. And I think being aware of, again, our own views and our own sort of anxieties or experiences or trauma with death and grief. But also, we're going to probably see clients who are grieving, especially now. Institutionalism. So thank you, Andrew, for mentioning the law earlier. So I think a lot of people have a hard time dealing with grief because there's so many other things to deal with when a client dies. So there's this instant sort of fear of like, am I going to get sued? Is the family going to go after me? What's actually going to happen? And this again stems from the suicide literature, which there is a lot of litigation after a client completes suicide towards the provider. Just again, out of anger, out of grief. It's not to attack the provider, but it's just some sort of obviously reaction to the loss. Administrative overload. So in New York State, I believe if a client dies, you have to send out like 4 different forms, especially if it's a part of an organization, like with OASIS. You have to fill out a form to Department of Justice, and then you have to like do discharge paperwork. It's like a whole thing. It's the last thing you want to do after you've lost somebody that you've been working with. And there's also the pressure of competence, right? We want to be good. We want to succeed. We want to have good outcomes, right? And again, pulling from the suicide literature, right, it can be really shaming to admit that one of your clients, didn't make it, or you lost one of your clients. And I'll note that this is particularly evident with trainees and students. So those of you working in academia or institutions where you're working with trainees, protect your trainees because they are in the early stages of their career and they're under a lot of pressure and they want to be good, they want to be strong, and they want to seem competent, and they want to get a good evaluation. And so for them, it would be even harder to lose a client to an overdose death, and then to seek any kind of support for that. There's a lack of professional guidelines on bereavement. So do you attend the services? Do you work with the family? Do you talk to the family? What do you do? And a lot of these discussions right now are sort of like, ethically, pros and cons and risks and benefits, and people talk to their colleagues and they make these decisions, and they're hard decisions. But there are no kind of guidelines of what you could do or what you should do. And I feel like that makes it hard because, again, all of this is in the context of active grief, right? And you're trying to make all these decisions. Do I do this? Do I not do this? And that's a lot. That's a lot to put on anybody. Intertwined personal and professional lives, right? So here I like to talk about it sort of in a twofold way. So one is, again, our own experiences of loss, our own experiences of trauma that may be related or unrelated to the clients we've lost. But also I think about peer workers, or people with lived experience, folks doing outreach in communities, and especially folks in rural areas where, there's not that anonymity. So yes, your client might be your client, but your client might also be your cousin's sister's son. And so it's not just that you're losing a client, you might be losing a friend, you might be losing a neighbor, you might be losing a colleague, right, as we've seen in the harm reduction world, unfortunately. And the folks who work together and live together and advocate together, so they're also losing those folks, right? So again, that might not apply to all the providers here, but it certainly does apply to a subgroup of us, particularly those working sort of more entrenched in the community. The remnants of the blank slate. So I saved this for last because I could literally have a whole talk just about that. So we know that I went to a very psychodynamic school, so there was this idea that the therapists, the providers, is sort of a blank slate, right? They're not there. They just sort of take on everything that the client is giving. And now we know that providers are, well, most of us, I don't know where you stand on the issue, but most of us know that therapy is a dyadic process, right? There's two humans sort of coming together and, a beautiful exchange, hopefully. But at the same time, the remnants of the blank slate sort of can impact us in a way where we don't feel comfortable even acknowledging that we can feel something for our clients. And when I don't write about grief or loss, I sometimes write about love, and I think it's the same idea. We have a hard time saying things like, I love my client, because that would expose us. That's too risky, that's too vulnerable, that's too unprofessional, taboo. So to say that I love this client and I'm grieving for this client has the same idea. And I'll pull out this wonderful quote from a really great book that is on providers' experiences of grief and mourning. Again, outside of the sort of overdose context, but still about mourning. And I think it speaks to it beautifully. We must be inhibited by feelings of shame, as though having strong feelings for our patients is taboo. We feel bereft, but unlike with any other loss, the world may not recognize that we are mourning. And so again, to me, that reminds me of those moments when I step into rooms and again feel no oxygen, because we're not naming that, we're not showing that we are mourning, we're not showing that, yes, 108,000 people, what a wild statistic, but that we might know some of these people, and we might have lost some of these people ourselves. So this talk is called On Loss and Wellness, so I'm gonna sort of transition to the wellness part. And the recommendations might be obvious because they address some of the things I already talked about, but I wanted to name them nonetheless. Of course, we want further research, right? So you saw some of the articles actually discussing providers' experiences with overdose, grief, and just drug-related death bereavement are pretty recent, like literally in the last couple of years. So we want to know more about what those experiences are like, what the barriers are. Again, a lot of the ones I named today are sort of taken from the literature that does exist and leans again on the suicide literature, the literature that talks about family members' experiences, but we need to know more. And of course, once we know more, we can actually inform individualized and context-specific recommendations. What is good for people in private practice, what is good for people in institutions, what is good for trainees or peer workers, right? Those all might be different things, different recommendations, so we just need to know more, first and foremost. More compassionate approach to substance use. Of course I'm gonna throw this in there. I mean, hello, where are we? So of course it helps, right? I mean, the same way that we've talked about countering stigma and bringing harm reduction to the forefront, I know this impacts how we deal with overdose death as well. So first and foremost, we do need to bring that approach to substance use as soon as possible. Comprehensive guidance for drug-related deaths. So again, there's so much to do administratively, and there's no guidelines, again, around like what we can do, what we can't do, what we should do, particularly, interestingly enough, about working with family members. And do we pull them in? Do we try to provide counseling, or is that wrong, or what do we do? And so I think having some kind of guidance, even if it's, especially if it's informed by providers, right? We want the providers to be in charge of this guidance, just to help clinicians feel more prepared and prevent those kind of frantic searches, all during a time of grief and intense difficulty. Institutionalized wellness, that's my favorite. So we've talked about self-compassion, we've talked about self-care, and all of that is, of course, incredibly important, and I hope many of you are already like, yeah, self-care, yeah, I know. And the reason I say institutionalized is because we really need to institutionalize wellness. It's one thing for me to say, like, oh yeah, drink your water, go get your nails done, whatever. But it's a whole another thing to look at it from a systemic level, right? Those of you working in agencies, check your policies. Are staff encouraged to take mental health days? Are there days that are specific to bereavement or grief? Andrew, you gave the example of feelings time in meetings. So is the structure of an agency or an organization set up to have positive morale and encourage wellness on a bigger level than just like, take care of yourself, you do good, because that's not enough, right? So we need to hit this at the institutional level. And if you are in independent practice, in private practice, I'm afraid to say that folks in private practice are at more risk because it can be more isolating to work in private practice. So, of course, I encourage peer support, right? Group supervision, joining the addictions division, wink, wink, where you can have a community, right? We know, again, from the suicide literature as well as the sort of beginning of the overdose bereavement literature, that seeking support is so important during a period of grief. So whatever you can do to have people around you, right, is crucially important. And I say this especially, again, for folks in in private practice, independent practice, but also, again, our trainees, our students, right? Folks who might be kind of forgotten as we think about these things. Training on death, dying, and grief, right? We do need this training. And that's, again, to help us become more comfortable with the topic, to also help us interrogate our own views on death, dying, grieving, but also just so that we can be more effective providers, right, to be able to talk about this. I will highlight that this is probably particularly important for those who do want to work with family members, so who do want to work with or have a specialty maybe in grief counseling. So of course that's going to be a key recommendation there. And lastly, of course, we want to reduce overdose deaths, right? So if you haven't bought into the harm reduction movement at this point, talk to me at lunch. I'll convince you, but essentially we do need to end the war on drugs, right? Because I don't want to give this talk. I don't want to talk about how to grieve overdose deaths. I don't want there to be a handbook on it. I don't want that to be our reality. So I think at sort of the biggest level, we need to curb this unprecedented death rate. We need to talk about harm reduction. We need to talk about naloxone. We need to carry it. We need to talk about safe consumption sites and about our role as providers in the harm reduction movement, the public health movement towards harm reduction as well, because we do have a very important role here. And I'll end. See, I'm very protective of lunchtime, so you're welcome. But when we were doing the presentation at the Harm Reduction Coalition conference during the fall, one of my colleagues, Michelle Mathis, who's amazing and works in harm reduction in North Carolina, and I asked her, my basic question of like, how has the overdose epidemic impacted you? And she said, some days it's why I do this work. Other days it's more like, why the fuck do I do this work? And I think it really captures, to me, it spoke because it captured this we can look at this rise in overdose deaths. We can look at all the tragedy and the trauma that has come to the communities that we care about. And yeah, some days it does motivate us, right? We wake up and we're like, I'm doing good work and important work, and I love what I do. And thank God for those days. And then other days, it's exhausting and demoralizing and sad and hard. And again, if you take anything away from this presentation, is that it's both, always. Thank you. Just a logistical note. For those of you who are doing CEs, please don't forget to sign out if you're stepping out for lunch, and then sign back in after you come back, because that's how we'll match you up with CEs. Anything else?